Oi, pessoal, tudo bem? Estamos aqui no 8º curso de nefropatologia do INP em Belo Horizonte. Eu, Gabriel Montezuma.
Oi, pessoal.
E o nosso convidado especial de hoje, que é o Dr. Alejandro, foi o convidado internacional do curso e deu uma aula brilhante sobre os desafios anatomopatológicos da gamopatia de significado renal, que eu acho que é um calo para muita gente que vive, né, com esse diagnóstico no dia a dia.
Exatamente. Esse, gente, para quem não entendeu, é o famoso curso do Stanley, né, de patologia renal, tá? Então, a gente vai fazer algumas perguntas para o nosso convidado e espero que vocês curtam.
A gente vai ter que falar inglês, tá? Para se comunicar, e a gente vai deixar aqui a legenda para todo mundo acompanhar também. So, hi, Dr. Alejandro. Thank you for your time and attention. And so, we're going to start asking, what is MGRS?
Sure. So MGRS, it stands for monoclonal gammopathy of renal significance. Gamopatía monoclonal de significancia renal.
Renal.
Yeah.
Perfect.
So it's a term that it's used for patients that have one, or actually more, because sometimes you have more than one or more types of renal diseases caused by a circulating monoclonal immunoglobulin that patient does not have otherwise any evidence of mass effect or a defined hematologic disorder. For example, you can have a patient with any form of, light chain deposition disease, amyloidosis, cryoglobulinemic glomerulonephritis, etc. But when you do the full hematologic workup, the patient does have a circulating immunoglobulin, like a positive SPEP or UPEP. But by the current hematologic criteria, the patient does not have a diagnosis of hematologic malignancy. So under the hematologist's eyes, the patient has an MGUS, monoclonal gammopathy of undetermined significance, with a renal lesion. So in order for those patients to get treatment, this term came about, monoclonal gammopathy of renal significance, to justify treatment for patients that they didn't used to before.
Perfect. And we saw that you were a co-author from a recent publication about it, right?
So what happened is that when this term came about, like a couple of decades ago, more and more interest and research started to develop on these type of monoclonal diseases of the kidney. So a lot of diseases have been described, and it's really difficult to keep up, right? The names of these diseases are very long, very confusing. They all sound similar.
Yeah.
And some people define them in one way, but other people use the term differently. So we thought it was important to write something. We're not really writing anything new. The only thing we did is have a clear one single document where we describe all these monoclonal immunoglobulin related renal diseases and come up with consensus criteria to diagnose them and helpful information that is not necessarily required to make a diagnosis, but can help you. So if you see the paper, there's a column with like required data and other column with helpful information. So the goal is for a pathologist that maybe it's not a full-time renal pathologist that does not see, because all this is rare. These are not common diseases, right? So for us, it's common because we see it every day. But for a pathologist that does everything, they may come across one of these not frequently, So it's really difficult to have a source where they can, anyway. So that was the goal, to standardize the nomenclature, to standardize the diagnostic criteria.
We have to speak the same language, right?
Exactly.
In different parts of the world. So we need that guidance.
Yeah, exactly.
We need that guidance.
One of our biggest challenges is when we find a monoclonal peak or evidence, and then we have increased creatinine or proteinuria or hematuria. We do the biopsy, and then we want to find an evidence that that disease, that CKD or AKI, is related to that monoclonal peak.
Yeah.
What's your protocol or your step-by-step to do the diagnosis?
Good question. So the way you describe it, it's ideal, right? The thing is that that's not real world. You know?
Exactly.
So if you always knew your patient had a monoclonal globulin, and we know this, I think everything would be easier. The thing is, sometimes we get a biopsy and we don't know anything about the patient because the workup has not started, right? The patient came in, and I'm not exactly sure how things work in Brazil in terms of timing, but at least in the US, sometimes they're in the ear and then there's a needle. So
It depends, Brazil.
so SPEP is not back, ANCA is not back, anti-GBM is not back. So it's different, right? Than when you have all the clinical information. But let's follow your scenario where you already know. That's easy because you're halfway there, right? You know the patient has a hematologic condition of some sort. So it's easier when you have a higher level of suspicion, right? The problem is that when you don't know, or when it's a younger patient where you're not suspecting a monoclonal process, so you always have, that's the number one to my answer to my protocol. When you review a biopsy, you cannot get too confident. So you always have to do a review in a systematic order. Look at the glomeruli, tubules, interstitium, vessels, because really what you're not expecting, you may not see, right? It's that happens. Even we're pathologists, we have trained eyes, we can pick up lesions, but you also need to be thinking of things. If not, especially when things are very subtle, very like a little bit of amyloid, it's easy to miss. We heard a really good lecture today about how it's not only doing a Congo red, but sometimes when you look at under fluorescence light, it's easier to detect minute pieces of or deposits of amyloid. So that's a good example with, if you're not thinking, if you have like, okay, this is a 40-year-old patient with nephrotic syndrome, you're not thinking amyloidosis. You're thinking a membranous or maybe minimal change or FSGS. You're not thinking. So you have to be very systematic and very disciplined when you review a biopsy, right? So you don't miss that. That's one thing. Second, you have to have the right tools and deploy them appropriately. That means always do your full immunofluorescence with kappa and lambda. Electron microscopy when available. Know that sometimes the immunofluorescence will be falsely negative, especially when you're talking about these type of monoclonal diseases. So ancillary tests like paraffin immunofluorescence, IgG subclasses, maybe mass spectrometry, but those are like a very, very, very small subset of patients that you need. Anyway, you need to know how to use all these tools and know when to order them, when not to, so that's kind of...
Maybe the last steps you do just if you have a high level of suspicion. So if you don't have that suspicious because the patient is diabetic or because he has like 70 years old and he has like a stable GFR or proteinuria, maybe it's more probable that it's another thing.
Yeah, and for example, it's important to set your own protocols internally. And I don't know, people who listen to this may not agree with this, but in our laboratory, we do a Congo red on every patient over 49 years of age.
Oh, really?
That's nice.
Because we know that sometimes it's so easy to... People can say, oh, it's excessive. I respect that opinion. But our numbers validate that's a justified... how many CBCs, complete blood counts, or chemistries a clinician does twice a day, So, you have your reasons why you're doing that as a clinician. As pathologists, we do things that they're required for us to feel comfortable that we're not missing something. So things like that, like doing Congo red on patients, even when otherwise there's no suspicion. Sometimes you get surprised. You find things. For example, talking about level of suspicion, if I have a patient with acute kidney injury and a monoclonal immunoglobulin, and I see acute tubular injury, even with a negative IF, always I'm going to do a paraffin kappa lambda, because we know that light chain proximal tubulopathy can be masked, for example. So that's a thing that I always do. Patient with AKI, acute tubular injury by morphology, and a spike, I do kappa lambda. So those things allow you that you're not going to miss things. And you have to follow your own protocols. I'm not saying mine are correct. They're just mine, and that's what I follow.
That's nice. And what would you say are the challenges for this diagnosis nowadays? The biggest?
Well, there's several.
Several.
Right? Like I said, if you don't do kidney all day long, it's hard to keep up, right? That's a true problem, right? Second, there's a lot of diseases now. There used to be 3. Now we have 16 well-described entities with 22 variants, right? That's a lot to have in your head, right? So that's a challenge. Second, what I was saying, you don't always have the complete clinical picture. That's a challenge. And another, I don't know if it's a challenge, it's an advantage, but it does make reading biopsies a little harder because, correctly so, clinicians are more aware of this. Nephrologists, hematologists order biopsies sometimes earlier to justify treatments, right? They have a patient that they're like, I know there's something going on, but right now I'm not fulfilling criteria. Let's do a biopsy and see if there's an MGRS lesion so I can treat this patient that I know. So because of that, we're seeing diseases at a much earlier. So you're at that point sometimes not fulfilling the diagnostic criterion yet, right? So that makes it a little bit harder as well. And also technically is very challenging. Not only is complicated to learn these diseases in real life, because it's not like black and white, it's threshold, right? So I get a lot of consults from my colleagues, and I consult a lot of the times my colleagues, because you're like, okay, kappa is brighter than lambda, but is it enough to go LCDD, for example? Is it so sometimes you're like, let me show someone else. So not having like a clear cutoff, it makes it difficult sometimes. Sometimes it's very obvious, but sometimes it's challenging.
Yeah, in Brazil, we have another challenge that we don't have all the tools everywhere.
Yeah.
So
Yeah.
electron microscopy, we have maybe 10 places or...
But that shouldn't stop you
Around
from
that.
practicing. You'll miss maybe 5% of biopsies. You know, there's certain situations where electron microscopy, but if you do it even without electron microscopy, you'll probably diagnose 90. I don't know. I'm making up numbers, but I'm saying most patients you will. It's better than say like, no, you cannot practice because you don't have electron microscopy. It's just you have to learn how to practice without electron microscopy, and try to get it when appropriate. Yeah.
Yeah, that's another challenge. We, as nephrologists and the pathologists also, we sometimes miss something because we lack knowledge of something that is always changing.
Yeah.
So maybe that's why we are doing this video for you. So we want to thank you again for participating, for agreeing.
Thank you. Absolutely.
And for your time.
Yeah. No, it's a pleasure.
It's a pleasure for us having you here. Eu espero que vocês tenham gostado, pessoal. Estamos abertos aí a perguntas e o que mais vocês queiram de interações nossas.
Tema sempre difícil, né? Mas tem que começar do começo, das definições.
Exatamente, pessoal. Abraço e até a próxima.